Welcome to Spectrum Sundays. I am Megan Sinisi, a Master of Health Science candidate studying to practice as a pediatric speech-language pathologist. I am also Miss Central Pennsylvania and the founder of a nonprofit organization for autism titled From a New Perspective.
And I am Francesca D'Alessandro, a current master's student at University of Buffalo studying speech-language pathology. Additionally, I am your Miss Thousand Islands of New York State, serving my community through AAA Appreciation and Awareness for Autism.
Everyone deserves to feel accepted and included in every space they walk in. Our series aims to inspire you to advocate for yourself and on behalf of your loved ones, and we are so grateful that you're here with us today. This week, we are very excited to welcome Michelle Dampf, who is a speech-language pathologist at the MU Thompson Center for Autism and Neurodevelopmental Disorders. She participates in interdisciplinary evaluations and provides intervention for patients with ASD and various speech and language disorders. Michelle also provides graduate student instruction for students at the University of Missouri Speech, Language, and Hearing Sciences program. She is a hub team member for the ECHO Autism Early Intervention Clinics and evaluates patients monthly through the Down Syndrome Clinic at the Thompson Center. Michelle also leads social language groups at the Thompson Center, which helps patients achieve the skills needed to be independent and employable. Thank you so much for being with us today, Michelle.
Thank you for having me.
Of course. We're really excited because we've actually heard and talked about the Thompson Center quite a bit on Spectrum Sundays. We had one of your students here, and a few months ago, we actually had a sibling of someone that was diagnosed with autism at the Thompson Center. So we're excited to see this come full circle. So to get started, could you tell us a little bit about your background of your education and what led you to pursue a SLP degree, specifically to support individuals with autism?
Yeah, I think that's a great question. And I just thinking what brought me to where I am right now. Going way back, I talked a lot in grade school and I always got in trouble for talking. I've always loved words and I love reading. And so it made sense that I would do something related to communication. I originally started college thinking I was going to do marine biology and get into dolphin communication. But then chemistry was pretty hard. So I took a turn and went for speech language pathology. So happy that I did. The autism interest really came later on. Autism was, I wouldn't say new, but just there weren't many people diagnosed with autism when I was in graduate school, but it was starting to become more and more, more and more was known about autism. So, and then after I graduated, got married, had kids, 2 of my daughters were born with hearing impairments, have cochlear implants. So it's interesting, you would think that would have been my passion and my path, which I know a ton about that, but really it's the autism. Like I don't know, maybe I can relate a little bit with the whole social communication piece, but I just really enjoy watching the progress with the children with autism that I work with and the families.
That's beautiful. And thank you for sharing about your daughters as well. We'll talk a little bit more about diagnosis and the process. So I'm sure that you've going through that as a parent yourself, that's helped you really relate to that. And I'm so glad that you're here today because we just know that we're going to learn so much from the knowledge that you've gained throughout the Thompson Center experience and all of your graduate study and clinician work. So thank you.
Yeah, I would love to pick your brain, and Megan will too later, about autism spectrum disorder, because it is such a wide, large range of different symptoms and characteristics. It can be comorbid with things like anxiety, depression, oppositional defiance disorder. There's a lot of things that can affect someone's symptoms. So it presents differently in every single individual. And we would like to know, what are some of the common underlying characteristics of ASD, autism spectrum disorder, and how is it differentiated from other communication and language disorders? Like there are some that are very similar. So we would like your input on that.
Yeah, I think that is a great question. And just, thinking about how the diagnostic criteria for autism spectrum disorder has changed throughout the years. And that kind of segues too into why are we seeing more of it? So whenever you hear about a child who may have autism, what do you see in that child that leads you to believe that? There are really 2 big things. And one is just having a lot of difficulty with that social communication piece, having difficulty initiating communication, initiating conversations, turn taking, understanding inferences, sarcasm, that super linguistic language is difficult. Younger children, like their play skills are going to be off. They're not going to be wanting so much to engage with their peers. They're going to be perfectly happy. Sometimes, you know, spinning the wheels on Thomas the Tank Engine, that's, you know, a happy playtime for them, or lining up objects, or collecting stuffed animals to the point that you can't walk in their room. So definitely some odd, you know, social communication, social characteristics, as well as that restricted interest and repetitive behaviors. Those are really the big identifying characteristics that are within the DSM diagnostic criteria at this time. And then as far as the educational identification of autism, that's pretty similar to the DSM criteria.
Yeah, you mentioned about spinning the train wheels on a tank engine and doing this behavior that's a little atypical, but we see that a lot, and that's often referred to as stimming. It's a very common behavior in individuals with autism. So could you talk a little bit more about stimming, and also how you might respond to family concerns regarding that behavior?
Absolutely. So a talk about stimming could take our whole time, so I'll try to make it as concise as possible. There are many different, so stimming is just almost a slang type term for the self-stimulatory behaviors that a child with autism tends to show. And then those stimming behaviors, when we're looking at the diagnosis, go into more of that repetitive behavior piece. So the self-stimulatory behaviors that you might see like finger flicking, you might see, you know, there's just like, there might be humming, it could be with the voice, there could be head banging, that could be some type of self-stimulatory behavior. And, you know, there's just smelling items, that could be something as well. So parents get concerned when it looks odd or different than what a neurotypical peer would look like whenever they're out and about. So it's okay, you know, to kind of work on that. And if the child's able to understand, it's okay to do that in this situation at home, in your room, in the living room, you know, in a more comfortable environment where you can teach them, you know, out in social, in the grocery store, or whatever. We want you to try to hold that back. It's not that it's harmful or wrong or going to hurt anything, but we also need to teach, you know, those social skills, and sometimes the stimming can get in the way. You also need to be careful about the self-injurious stimming behaviors. So like the head banging, that's something you definitely want to work with, like a BCBA, to try to correct that behavior or figure out why it's happening. I mean, with behaviors being communication, that could totally be communicating, I have a headache, whenever they don't have any other way to do it.
Yeah, I think something we've learned from a lot of our self-advocates is some of the stimming behaviors they want normalized, but some of the more injurious and dangerous ones should definitely be worked on through therapy. And I think it's really important to make that distinction like you did. Thank you for talking about that. But as mentioned earlier, you are a hub team member for the Autism Early Intervention Clinic. So could you speak a little bit about the importance of early intervention and identification of autism and the long-term benefits that early diagnosis can have for that individual?
Absolutely. One thing that I talk to parents about, and sometimes they look at me a little funny whenever we are setting goals and looking toward the future, is we talk about employability, we talk about independence, and we talk about confidence. So those are three things that I really want to work and make sure that my goals are moving in that direction for a child. Even when they're 5 years old, I'll bring that up to parents. So that way they can see, you know, the earlier you can start teaching life skills, the earlier that child's going to be more independent. And that's what we want, to get more and more of that independence. So a child with autism, you know, they may need to be taught things more explicitly than a neurotypical peer might, but it doesn't mean they can't ever do it. It just takes a little bit more. And so the earlier you get that diagnosis, the more time you have to teach before that child turns 18 and is ready to go to college, or, you know, any type of post-secondary education or employing. And then, you know, we have to do a better job with getting our children with autism to transition into the adult world. And it has to start very early on.
Absolutely. And You know, that's part of why we do Spectrum Sundays, to raise the awareness and to make sure people know what the signs and symptoms of autism are at a very young age. That way we can get them the therapy that they need so they can meet their full potential, so that they're matched with functional goals that will help them get to that employability someday in the future. And I love that you bring that up about how we need to think about that very early, because it's so easy to fall into that, in my experience as a graduate clinician, to do isolated tasks that are very specific to the goal, but might not transfer to other circumstances that the child can actually apply that skill. So that's absolutely important. And something that I feel very fortunate as a Mizzou student at the University of Missouri is the Thompson Center takes a very interdisciplinary approach to evaluation and intervention with autism, which I feel like lends to that functionality of skills. So what does the process look like at the Thompson Center, and how is that approach especially beneficial for patients that come to the Thompson Center?
So the Thompson Center is just, I can't say enough good things about what we have to offer for families. So we start with that evaluation process, right? And when we have a child who's not clear on their diagnosis, it takes a team of professionals to make sure that we are identifying that child correctly with autism or with another, area of concern. So our interdisciplinary clinic, we have a psychologist. We also have a psych tech. So our psychologist is able to do the diagnostic interview while our psych tech is actually testing the child with whatever our area of concern is. So if they're looking at anxiety, if they're looking at cognitive, they're looking at ADHD, attention issues, whatever they're looking at, that psych tech can help. We also have an occupational therapist on our team. She's fabulous, and it's just so great to have all these eyes and ears in on a child, to be able to weigh in as a team on where we feel like this child is on strengths and weaknesses. And then my job, or the other SLP at the Thompson Center, our job is to look at the language skills of a child. And it sounds kind of simple, but we're really looking at pretty specific areas for that team. Once that child gets that diagnosis, if they get that diagnosis of autism, they have access to all of the resources at the Thompson Center. So they can see, we have a psychiatrist on staff. We have developmental pediatricians who work with us. They can come back for a psychology evaluation. They can get intervention through the social language groups or through speech language therapy, through our occupational therapist. We have ABA, so they can, have their ABA therapy. We have numerous BCBAs, and then their students, their RBTs. We have a training division that goes out and trains schools and businesses. We have just so many things to offer. And I get so excited being able to help parents in so many different ways whenever they come into the Thompson Center. It's a tough day when they get that diagnosis. And so just reminding them, the child is the same child you walked in the door with. Nothing changed except they have this new label, or medical diagnosis. Everything else is the same. That child is still has the same strengths as whenever he or she came in. So just, trying to help the parents see beyond that label of autism spectrum disorder.
Right. And as a student, being able to watch that process unfold in my own diagnostic clinical experience, it's really awesome to see how all the different team members have something very valuable to contribute to that evaluation process. And it can't be done without any of the other pieces and parts weighing in, because we all have such a very specific and awesome skill set that contributes to that accurate diagnosis to meet the needs of the child that walks through the door.
And I think you both gave really great examples of how intercollaboration can really be successful. But for some who might be struggling in for a collaborative team of professionals, what do you think is the most important thing to keep in mind when working with other professionals in other disciplines?
After working in numerous environments, I've been an SLP for quite a few years, so I've had lots of different experiences. I would say number one is respect. You have to respect the other disciplines. You have to realize that, yes, as an SLP, we know a lot. We are trained on a lot. We have that education on all different areas of communication, but there's still so many more aspects to the child, to the family. So taking into account what the psychologist says and being like, oh, wow, okay, that's a different perspective that I didn't have. Taking into account what our occupational therapy, and being able to even use some of that in your own therapy and giving them some ideas, working with your BCBAs. You know, they need a little bit of help with the communication. We need a little bit of help with the behavior. So take what you can get from the other professionals and use it, and just, you know, actively listen to everybody, and just, you know, lose any type of, I don't know how to say it, I guess, exactly. Just being very respectful and kind, and listening, and also not being afraid to offer your own expertise. Being able to have discussions that I may not agree with what the psychologist has seen, or I may see things a little differently, and being able to have those respectful discussions so that you can really help the family and that child, that you're really considering everything in the whole, you know, picture, getting the whole picture.
Right. I'm really glad that you pointed that out, because a lot of times professionals even, but the general public especially, have a misconception about what SLPs do. We're often seen as just the therapists that help children say their sounds properly. So if you could get up on your soapbox for a minute and preach to our audience about what specifically you do as an SLP in the autism evaluation process, what does that look like, and how is your specific skill set adequate for that piece of the evaluation?
Yeah, absolutely. So when we're in an interdisciplinary evaluation, it's a little bit different than what you would think of a comprehensive language evaluation. And I treat both of those differently. So in the interdisciplinary evaluation at the Thompson Center, we call them our comprehensive assessment teams, or our CAT clinics. Our big question that we have to answer is, does this child have autism or not? And if we can answer other questions and you look at some differential diagnoses, you know, that's important for the team to do as well. But that's our big question 90% of the time. Does the child have autism or not? So what my job is, number one, I have to determine their language level, because the test that our psychologists give is the ADOS, or the Autism Diagnostic Observation Schedule, which is, you know, you'll hear it referred to as the gold standard. It is an amazing assessment for being able to really pull some of those autism symptoms when you're looking at a child for diagnosis. But with that Autism Diagnostic Observation Schedule, with the ADOS, there are different modules, and the different modules depend on the language level of the child. So it's really the SLP's job to determine that language level of the child so that the correct module of the ADOS can be given. If I determine that the child's language level is lower than what it actually is, that child may look like they have autism because they've been given a module that's too high, or vice versa, may get a module that's too low and they may look better than what they actually are, and we may miss the autism on that. So that's an important piece of my evaluation. The other piece is I do have to determine if there's a language disorder or not, because they can coexist together. You know, we can have comorbid ASD and a language disorder. And so it's very important to determine if that's an issue, and if it is, to thoroughly explain it to parents, because really the only word they're hearing is autism, autism, autism. And when you talk about a language disorder in addition to that, that's a pretty significant event for a child, and that's a pretty significant disability for a child to have to deal with. So we have to be very explicit in how we explain things to parents so that they leave understanding, yes, my child has autism and my child has a language disorder. So that's all part of that. And then the third thing is I really have to take a great look at those social communication skills. I have to help the team determine where this child's social communication strengths and weaknesses are. That ADOS does pull for some of those, so they will get some of that information there, but I also have to be able to support that and then provide ideas for goals and objectives for the child if they are in need of therapy. Lots of areas to look at.
Yeah, and when going through your CV, I noticed that you actually have some experience with the role of gender and autism and how it presents. And it's something that's been brought up on our series before with different self-advocates. and how they've had a later diagnosis because of some of the symptoms, and they believe it's due to their gender. And we are still exploring this topic because we know that there could be the factor of non-binary genders and its role in autism, but for now we have a lot of emerging research in female versus male. So I was wondering if you could clarify how it might present differently in the male gender versus the female gender, and if you know anything about non-binary gender as well.
Yeah, so I think that's a great question, and this is a great time to talk about that. There has been just more and more research on the difference between the males and females with autism. With the boys, I mean, there's always been that thought that there are more boys than girls with autism. So the tests are primarily standardized on the male population with autism. What we're finding is that girls and boys are just different, right? There's different characteristics. Same thing with autism. A girl with autism is going to have different characteristics than a boy with autism. They're going to have the basic diagnostic criteria the same. So they're both going to have issues with social communication skills. It just may look a little bit different in a boy and a girl. They're both going to have issues with that repetitive behavior or that restricted interest. What girls tend to do is, like if they're at school, they tend to understand the importance of doing their best to hold it together, I guess. And then once they get home, they fall apart. And that's what I hear a lot with when I talk to the parents of the girls that are in my social group. They'll be like, yes, absolutely. 3 p.m. hits and she gets home and she's comfortable at home and she just falls apart because she's been working so hard to hold it together. The other thing with girls is that their intense interest, their restricted interest may be a little more socially acceptable than the boys. So the boys may talk about dinosaurs, and it gets to be just a little much. Or they may line up, their dinosaurs straight in a row or their Hot Wheels straight in a row. Girls, their intense interest might be baby dolls, which we see a lot in girls, right? So it just kind of goes along with it. It's not until they get a little bit older and you're like, okay, so you're 10 and you're still carrying around a baby doll. That's a little bit odd, that it starts to kind of show in the girls. The girls make their intense interests look a little more socially acceptable, where the boys don't seem to care as much if it's socially acceptable or not. The girls with autism, they know they're not quite fitting in. They want to fit in, they're just not quite sure how. And the boys as a whole are just kind of like, I'm good. Whatever it is that I'm interested in.
Yeah, we've actually spoken with a few different guests on Spectrum Sundays who didn't receive a diagnosis until later life, about in their 20s, who were girls. And they mentioned about masking and how they were able to cover it up a little bit better throughout their lifetime. But then by the time they're 20, they've gone through most of their life without being given the supports that they needed that could have helped them thrive a little bit sooner. And fortunately, it seems that they were still able to be successful in their life, but it makes us wonder how much more they could have accomplished if their needs were met a little bit sooner, if that was identified a little bit sooner. So I love that you pointed out that these standardized assessments that we have oftentimes don't reflect how girls present with autism or exactly the way that they might present with autism. So we might be picking up the girls that are very apparent with their autistic characteristics, but some might still be falling through the cracks. So that, that's what's so exciting about our profession, is that our job is never done. We're constantly learning and researching. So hopefully we're able to fill that gap pretty soon.
The girls who have autism tend to have more diagnoses of depression and anxiety than the boys do. And this is pretty early on in the research, but it makes sense in the anecdotal evidence that I see on a daily daily basis because they know something's just not quite right. They just don't know what it is. So then, you know, that anxiety develops and what's going on and why isn't anybody wanting to talk to me, and all of that stuff, along with the depression, can really hit in. And that's what worries me about our girls with autism and not getting that diagnosis earlier is, you know, the more of the mental health issues that start to set in.
Absolutely. And obviously, whenever we're talking about a diagnosis as soon as possible, that can be pretty overwhelming for a parent, especially if they haven't gone through that process before, if they don't have any other children that have received any diagnosis for that matter, not just autism. So it's a difficult and it's a challenging process that you probably have to tiptoe your way through. But at the Thompson Center, how do you help support families and counsel them through that process that is oftentimes an unknown experience? And how do you do that before, during, and after the evaluation?
Yeah, so if it's before the evaluation, we take a lot of information. We get a lot of information from the families, and we try to get the best picture that we can of their child so that we can make sure that we are giving them, you know, the most accurate diagnosis possible during the evaluation. So sometimes what happens in our clinical assessment team evaluations is that on paper, when the parent's filling it out, there's a form that they have to fill out, and it kind of looks at some autism symptoms. And if it looks like, well, this parent's not really seeing any autism symptoms, but the pediatrician recommended they come for an autism eval, once we get our eyes on them and see them at the beginning of our evaluation, we can, you know, we start as a team, we're like, oh, wow, you know, we're starting to see this, we see this, we're starting to see some signs and symptoms of autism. We, in our feedback, start to sprinkle in just a little bit of information about autism so that at the end of their evaluation, which typically takes about 4 hours, they're not blindsided with that diagnosis. So after I do my evaluation, I go give feedback to mom or dad or caretakers. I might say, I do see some social communication concerns. I will outline exactly what those are. And I will also let them know, you know, sometimes these social communication concerns can be consistent with a diagnosis of autism. I'm very clear with the parents that I'm not saying right now at this point in our evaluation that your child does have it or doesn't have it, but I am starting to see, you know, I am seeing some signs of it, of possibly having it. And then when our occupational therapist goes in, she might say something similar, where what signs or symptoms she saw. And then lastly, our psychologist comes in and gives that feedback to the parents with the, you know, diagnosis of, yes, your child does have autism spectrum disorder. This is what that means. So we've already given the parent, okay, well, maybe he does have autism. So they've got a little bit of that throughout their morning or their afternoon. So whenever the psychologist comes in, it's not the first time they're hearing the word. It's not the first time they're thinking their child may have some of the signs and symptoms. Once they receive that diagnosis, our psychologists at the Thompson Center are amazing with family-centered care and feedback. Very, we take I'm not the psychologist, but they take their time. They give that feedback slowly. They ask questions along the way. The one thing that I love is that they don't say, well, do you have any questions? They say, what questions do you have? How can I help you? And then we also give the parent a guide, the first 100 days, which is your first 100 days with a child with a diagnosis of autism, very like a roadmap on what to do. You know, what do I do next, step by step. We also give the parents opportunities to attend our parent trainings. We have a next steps workshop, which is now offered virtually. So the parents can attend that. They can learn more about autism. We give them the opportunity to make medical appointments if they want to see our psychiatrist or they want to see our developmental pediatrician. And then our medical doctors follow that child throughout their life as they grow up and knows that child. So as they enter puberty or new symptoms come up of this, that, or the other, they're really good care there. So I feel like we do a really nice job of taking care of those parents. That diagnosis, that day is just hard and it's overwhelming. So we do the best that we can to really have fun with that child while they're there, you know, make it a positive experience, but also take care of the family too.
Yeah, I think everything you just explained reiterates what we were talking about earlier of how important successful collaboration between different disciplines can be, especially when having to go through the grieving process with the parents as they're learning about the diagnosis of their child, and also learning how to treat their child in the future. Mm-hmm. So earlier, we also talked about the increase in prevalence of autism spectrum disorder as a diagnosis. For example, in 2000, it was 1 in 200, whereas now it's 1 in every 59 children are diagnosed with autism spectrum disorder. We talked a little bit about why it's increased. So I know it's been classified as an epidemic, which can sound really scary. And as part of someone who gives that diagnosis to a child or helps with that process, what can you clarify some of the mythology that is behind why autism occurs, and just words of encouragement for someone who is experiencing that right now as a first diagnosis?
Yeah, so autism, it does, just look from the outside in, it does look like, oh my gosh, everybody's getting a diagnosis of autism. But honestly, what has happened is that our diagnostic statistics manual has changed in the way that autism is diagnosed and the criteria for diagnosing autism. There used to be 4 criteria for diagnosing autism, and now there's 2. So that leads to, a lot more people can fit under that umbrella than having to fit into all 4. And so, like I said earlier, really we're looking at specifics, but if we want to keep it broad and simple, those social communication deficits, the restricted interests, the repetitive behaviors, whenever we look deeper into that, that's really where we get it. And so when I think about my grade school way back when, I didn't have anybody, maybe one person in my school was diagnosed with autism, and they would have been considered like a level 3, needing some very substantial support. But I also think about some kids in my class that didn't quite fit in socially, that may have sat and rocked in their chair. And so I'm thinking, wow, if they were at that age now, they would most likely get that diagnosis of autism and be able to receive some support so that they could be successful later on, instead of people looking at them going, oh my gosh, thinking different things that didn't allow them to get that social interaction or positive social interaction. So with that diagnostic criteria, it is broader. And then we have our, different levels of support. So for, a child who has a level 3 need for support in the restricted interest and repetitive behaviors, and a level 3 in the social communication, that child is going to be someone that you can probably tell pretty quickly that they have autism. They're going to need substantial support. They may be nonverbal, maybe need an augmentative communication device or a speech generating device. And then you move on down to the level 2, which is just requiring substantial support, not quite as much as a child who's nonverbal, just needs a social language group to try to help with some of those skills. So there's different levels, and every level needs some support. So every child at each of those levels needs support.
Absolutely. And it's been very fascinating over even just the past decade to see how much research has grown, and as intimidating as it is to see that statistic become very small, 1 in 59 versus 1 in 200, I would like to think that that's just a blessing in disguise is the best way that I could probably put it, because it doesn't necessarily mean that, like you said earlier, once someone receives a diagnosis that their life changes or it makes them a different child. It just gives them access to the services that they might need, and then makes that applicable in their education and then future employment. So I try to look at it that way. But you also mentioned about levels, and we know that medical terminology changes all the time, and it's constantly being reevaluated and updated. And a lot of times we hear the words high functioning and low functioning being tossed around and used as classifications. So how could these labels be potentially harmful? And then what's best practice for categorizing the level of needs for individuals?
That's a great question. And I think it's a question a lot of people have, but they're not sure exactly how to put that into words, because whenever we use high functioning and low functioning, that's simple. We all get a picture in our mind and, we're like, okay, we've got it. The problem with labeling a child with autism spectrum disorder with high functioning or low functioning, in doing that, sometimes you can get the picture in your head that a child who is high functioning doesn't need support. They're doing fine, which is not true. So their grades may be great. They may be getting all A's, but they're not independent. They're not employable. They don't have the skills to transition from high school into post-secondary education or employment. They don't have the skills to live in an apartment on their own. So it's important to, when we diagnose autism spectrum disorder, to be very, like explicit with parents. And we get parents ask the question all the time, so is this high functioning? And so we explain the levels, our psychologist explain the levels, and also explain, although your child may be at a level 1 for the social communication and a level 1 for the RRBs, there's still some support that's needed there. And if not at age 5, at age 9, at age 14, at age 21, the child's most likely going to need some type of support. It may not be much, but it will be something. And you want to make sure that that door is open so that any child who's diagnosed with autism spectrum disorder can get the supports that they need. If we say high functioning, some people may close the door on those supports.
Yeah, that was a great explanation of all of that, because it can be a loaded question, and it's so important to always be open-minded, especially when working with a disorder that is still being explored. And actually, so as we continue to learn more about autism, treatment, and evaluation, what are some evidence-based resources that you frequently use to fine-tune your knowledge and best serve this population?
That's a wonderful question, Frank. I love it. I would love to see every SLP making sure that they are using true evidence-based practices. The problem that's happening right now is that any program that's coming out, that's you're getting the flyers for, that's in the magazines, is saying we are evidence-based. This is an evidence-based program. So you really have to know what's meant by that. Evidence-based, truly evidence-based. You're able to duplicate, replicate those studies. It is peer reviewed. It is not just 1 or 2 studies from the company that developed the program and then it's evidence-based. No, truly needs to be well researched. Your child is only young for a short amount of time. You do not want to waste those years on something that is not proven to be effective for a child with autism. So I love this question, and I just really hope that somebody learned something from this answer, that be very, very careful about evidence-based, because that term is so cliche at this point and it's thrown around so much, that to truly understand what true evidence-based means. I will tell you, visual supports are my #1 for children with autism. I encourage visual schedules, visual daily schedules. I encourage visual schedules during your therapy session, even if it's only 4 things. Let that child check it off. Let that child take the Velcro item off. They don't have to be difficult or detailed. You can have simple visual supports, and those are huge for children with autism. They help with all kids, really, but very, very, visual supports are an evidence-based practice for children with autism. So those visual schedules, use them. Social narratives, when you write them, just make sure they're in the positive. Instead of saying, don't walk or don't run in the hall, we need to say walk in the hallway. Any of those negations are difficult for children with autism to understand. So everything needs to be written in the positive for your social narratives. PECS, the Picture Exchange Communication Program. If you have a child who's nonverbal, you darn well start there. That is the best place to start for getting a child to initiate communication. A child with autism does not, it's not that they don't have the desire, it's there. You just don't see the desire, and they have a very difficult time showing you that they have that desire to communicate. So phase 1 of PECS, it's hand over hand. You're working with two adults to try to get that child to understand what you're doing with PECS. moving forward from there. The biggest problem that I see with PECS is that clinicians don't implement it correctly, and then they're like, well, PECS didn't work. If you follow the protocol, it is an incredibly evidence-based program. It will work. I would, I don't know the percentage. Anecdotally, I would say 90% of the time it works. And then being able to move from PECS into a more functional form of communication where you have more access to vocabulary. So it might be a speech generating device, or it might be verbal. I mean, PECS can facilitate the verbal language. Speech generating devices can facilitate the verbal language. So that's one thing too, we try to help parents to remember. Video modeling is a huge evidence-based practice that works so well. The one that I use the most is everydayspeech.org. It is you do have to pay for the membership, but I feel like it's worth it. I use it for all of my social language groups. YouTube has a bunch too. And then video self-modeling, I would say, is probably, when they're a little bit older, it's one of the most effective. If you can videotape a child having a conversation and then play it back and say, okay, great, what went well? What did you do well? What didn't go so well? Let's talk about that too. They'll listen a lot more than if you're saying, well, you talked too much during that conversation. They'll say, no, I didn't. You really can't argue that point. But if you have the video self-model, you can certainly just show them and talk about it.
Right. I'm so glad that we asked you that, and I'm so glad that you gave such a stern response and a stern answer, because especially right now, we're getting almost all of our information on the internet, and parents are being required to take a role that they have never had to step in before. So whenever therapy isn't being met because of the pandemic and they're doing things virtually, parents need to turn to more resources. So being able to tell them that there are some evidence-based programs out there, but you have to be selective in choosing them. And you have to know that it's not a one size fits all, and it's not going to fix everything overnight. And I feel like that's where there's a big misconception, because of course we want our kids to have access to communication and we want to alleviate some of their challenges for them, but it's a process. So letting that process play itself out in therapy and in different interventions to help them really fine tune what they're working on. So thank you so much for elaborating on that. And I feel like we just scratched the surface of all the important work that you do as an autism professional. But as we wrap up today and anticipate your next episode with us, what advice would you share with anyone who might be interested in pursuing a career in the therapy professions?
Just do it. I have absolutely loved every aspect of my career as a speech language pathologist. I started out in the schools. I loved being in the schools. I just enjoy all of it. And I really haven't met an SLP who hates their job, because if you're not happy in one setting, you can go to a rehab, you can go to an outpatient, you can do babies in the NICU, you can do adults in, the hospitals, the outpatient, the inpatient. There's just so much you can do with a career as a speech language pathologist. Go for it.
That is great advice. And that's what I especially love about our field is we can always, as we grow as humans, we can also grow within our profession, with wherever we land. But thank you so much for visiting with us, Michelle. We really enjoyed having you here with us today. And if you also enjoyed this episode, please make sure to keep an eye out for Michelle's second interview with us, where we'll be discussing advocacy, speech language intervention for individuals with autism, and her role as a clinical supervisor at the University of Missouri. So thank you, everyone, and we'll see you next Sunday.
Thank you for listening to Spectrum Sundays. We are your hosts, Miss Central Pennsylvania, Megan Sinisi,
and Miss Thousand Islands, Francesca D'Alessandro. Please make sure to subscribe to our series and follow us on social media to stay connected to autism professionals and self-advocates.
And just remember, true impact is accomplished through active listening and exploring the world through a variety of perspectives.
Join us next week on Spectrum Sundays to help cultivate a community of inclusion, appreciation, and acceptance around autism.